Okay, so first of all, there will be a prize for whoever in the audience at the end of this presentation is able to count and tell me correctly the number of common slides between Dr. Shashinsky's presentation and mine, okay? So the title is really what it means. This statement, our current inclination is that surgery may or may not be useful in patients with non-bulky minimal and N2 disease. Principle may be true. Aggressive chemoradiotherapy is equally effective. There are patients whom chemoradiotherapy may be effective in eradicating regional nodal disease as well as occult micrometastatic disease. Surgical surgery may be very important. Okay, this was a very important statement. 2010, Dr. Shashinsky. Thank you very much. So from my standpoint, there is no disagreement between Mark and me, which will come out with this lecture. But what is the crucial thing about this lecture is that, as he quotes Frank Dieterbeck with a reasonable series of related claims which mean nothing, and then the slippery slope about what to do in these patients, the ultimate resolution is here, and if you don't do it there, and you don't document how you do it there, and you don't try to be consistent, then you're not doing the standard of care. There's one, and we won't dwell on that, but I do like at least some consensus. So when I had to give the speech earlier this year, I looked up what the most recent consensus was from our European friends who are the haters of this also. And the first thing is you better make sure you have a diagnosis. That's number one, so that you know that you have clearly histologically positive disease, plus also it'll give you an idea of what the extent of the disease is with numbers of lymph nodes. So I won't dwell on that, but I think that at least from the consensus, they want to classify patients as being incidental N2. That's so easy. I mean, those patients obviously, I mean, if you find them, you give them postoperative adjuvant therapy. If you have a single node, do you operate on that patient? Single node on a mediastinoscopy, do you operate on that patient and then give adjuvant therapy? I don't. I refer them to Mark. Single node mediastinal disease, and then we'll talk about operating on them afterwards. Then you have the ones that Mark spent time on, which is the potentially resectable N2 disease. And they're potentially resectable depending upon the eye of the surgeon. And you've seen these perfunctory pictures. This is a different picture of quote, resectable N2 disease with a nice fat lymph node at the mid-level 4 zone seen there. And obviously this is unresectable. And how does a surgeon look at this? Well, frankly, I think it is like pornography, in that, you know, there was that famous case that went to the Supreme Court, and the lawyer was talking about whether these people should go to jail because of pornography, and he said, I'm not going to attempt to define the kinds of material, but I know it when I see it. And the motion picture involved in this case is not that, which means, just like in MDL, the surgeon says, why is this particular case unresectable? It's tough to say, but I know it when I see it. So it's just like the pornographic sort of reading that we had before. Number two, but more that's related, number two, which is that, yes, if you have more numbers of nodes, it turns out that there's a little bit of wonder about whether you really die quicker, because the overall survival is about the same, but the disease-free survival is not the same, depending upon the number of mediastinal lymph nodes. I personally believe that the number of nodes does make a difference because it influences tumor bulk and resectability. So, and in every other review of whether multiple nodes makes a difference, it does make a difference, because below that are the non-induction types of just surgery trials with 3A. And then as you move upwards and you look at multi-station N2 versus single-station N2 in the chemoradiation or induction groups with surgery, multi-station N2 just does not do that well. But it depends upon, is it multi-station microscopic? Is it 2 stations? Is it 4 stations? Those are the issues. Now, medical oncologists and surgeons don't agree on this anyway, but they do agree on some things. And single-station nodal disease, in this review that actually Mark has published with Dr. Virmanchani before, surgery and medical oncologists agree that single-station microscopic disease is surgical disease. However, when you get to multi-station disease, that's where the differences come. But is it multi-station disease with bulk nodal disease that you can't do a good operation on? What does that really mean? So you know what you can do. The question is, what is the right thing to do, and what is the compromise thing to do for these patients as far as surgery? Well, you know, there's 2 ways in which this went together. The one was chemo alone, and the one was chemo and radiation therapy. And I don't dismiss the idea of chemo alone for early, very early, non-bulky N2 disease. At least some institutions are doing that. And at least they didn't show much difference early, but when the Bedecker trial with cis and docetaxel came out, there were some interesting findings with a large response rate and some promising median survivals, but that really never really influenced therapy because chemoradiation therapy went to 4. And in fact, if you look at Jack Roth's series from MD Anderson now, in which they gave only induction chemotherapy and then operated, and you look at their results, first of all, we talked about staging. Only 18% of those MD Anderson patients got histologically staged. Please remember that. And second of all, the local recurrence rate was 31%. So radiation, I think, is a crucial part of this in the majority of cases if the patient's going to be able to tolerate induction chemoradiation. On the other side, you come to this, which is the intergroup 0139 trial, and indeed there will be no consensus on this in that Mark hates the lobectomy idea. His points are well taken because indeed I think this was put up to not scare surgeons, which means that if you do a pneumonectomy, you kill patients. If you do a lobectomy, they still stay alive. And I think that was one of the reasons for this. But what really we take away that's common is the idea of downstaging. And to me, that is the unconquerable situation in this disease, in that, tell me the trial, the modern trial of chemoradiation therapy versus chemoradiation therapy and surgery that has used modern endoscopic techniques to be able to restage patients in both groups after treatment. There are none. And that is the only way you will solve this issue, in that you would have a trial with modern endoscopic techniques to be able to document whether you have residual disease. Now, the idea of tumor clones in the primary is a very good one, which may be picked up by PET, who knows, or by a percutaneous biopsy. But for nodal disease, we have better ways now of finding out what's going on. I'm not going to dwell on this because we agree to disagree on this, although I think we do agree that the importance of downstaging of disease, whether by chemoradiation therapy alone or chemoradiation therapy combined with surgery for local control, is important. But at least from the consensus group, they say that, yeah, you can operate on these patients, but you know, you got to give full dose radiation therapy also. The other question is, where is the randomized trial of whether you do induction chemo versus induction chemo-RT in surgery? Well, there is one trial that was just published, which has a very weak link also, and that's the SAC trial. This just was published, presented at ESMO, in which they randomized patients to either get induction chemo or chemoradiation therapy, and then the patients get operated on because they wanted to see whether there was any influence of the radiation therapy. But this was not concurrent. This was given afterwards. And the responses were better with radiation therapy. The amount of surgery was about the same, but there was absolutely no difference. Now, again, this is not concurrent chemoradiation therapy, so that's a big flaw in this trial. So we still don't know whether radiation therapy is a crucial local component, but I agree with absolutely what Mark says. It is a crucial component, no matter whether you're going to do surgery or not. But how much radiation therapy and how much nodal downstaging? And despite the fact that 0718 didn't show that higher doses were any good, at least the Maryland group was able to, well, this is from the Maryland, this is a trial that didn't pass, so we have no stage 3 trials that are actually going on now. But let me show you, I don't have that. The question is whether you can downstage more with higher doses of radiation therapy, and the Maryland group actually showed that you could, and you could do it safely. So I don't know whether you should give higher doses now, but what they did do is they reinforced the idea that you should give full dose radiation therapy, curative potential level, 66 gray, for any patient that you're considering for surgery, and it can be done safely. I want to get back as my last point to the restaging nightmare, which is, how do you know who to operate on or not? Because the ideal situation for a surgeon is that the nodes aren't persistently positive when you operate on them. So this is a trial that was done to try to answer that question, in which they used EBUS to see how good it would be to pick up nodal disease afterwards. And actually, despite the early data that apparently EBUS was not good after induction chemoradiation therapy, the positive predictive value was excellent in this, as well as the negative predictive value. And if you can have this information on a consistent basis as a surgeon before you operate, you will make decisions not to operate on these patients. And I think that's the way we have to be consistent as surgeons with this disease. And the question is whether you had to do both bronchoscopies and EUS. Well, this is a technique where you did both of them with a bronchoscope, where you could biopsy not only the lower nodes, but the upper nodes, just sticking the bronchoscope all the way down and doing an EUS. And they found that there was excellent positive predictive value and negative predictive value using these techniques. We're now at the point where there's justification that we can get answers on this disease after treatment to really answer this question without having the bias of whether the nodal downstaging is really chemosensitivity or whether the surgery is doing something. We'd be able to know in both groups what the status is after the chemoradiation therapy. So I really, this is not a debate. I mean, having lived through this, I'm one of the surgeons that don't operate on everybody. I try to avoid pneumonectomies on the right side in these patients after chemoradiation therapy. But if you have a patient that has been treated with chemoradiation therapy and develops a big, large abscess, and they're starting to cough up blood, and that's in the middle of therapy, which I've had, and they have to be salvaged, I will do that for the patient, and I have done that. But I avoid right pneumonectomies now. And yes, we discuss every case as far as the bulk of disease and whether we think we can do an operation up front. If we do not think we can do a good operation up front in the MDL, then we don't consider that patient's going to be a surgical candidate at the end. It depends upon your surgeon who you deal with. But otherwise, I agree that with Mark, the majority of these patients, all of them should have chemoradiation therapy, but not all of them should have surgery, even if it's just a lobectomy. Thank you.